This is the Best Health Podcast, brought to you by Wake Forest Baptist Health in partnership with MedCost.
Good day, everyone. Welcome to the June edition of the Best Health Podcast, brought to you by Wake Forest Baptist Health in partnership with MedCost. I hope you all are having a lovely June so far. I have a very special guest with us this month, Dr. Chris Tuohy, who is on our orthopedic and musculoskeletal service line team here at Wake Forest Baptist Health. Welcome, Dr. Tuohy. How's it going?
Great. Thanks for having me.
Hey, no, thank you for taking time. I know you have a very busy schedule, so thanks for taking time and hanging out with us on the Best Health Podcast this month. We're going to talk about maybe some common hand injuries or ailments or shoulder or elbow here in a little while. So we're going to get into some medical questions in a minute. But before we dive into that, do you mind just telling us a little bit about yourself and where you're from and how in the world you got into orthopedic medicine?
Sure, I'd be happy to. I'm originally from the Northeast, like a lot of people. I grew up actually outside Philadelphia.
Okay.
But even independent of that, I was born in New York City. So, the last name's Irish. Sometimes I've got some patients coming in to see me that have this idea that with the name Tuohy, that it's going to be Asian. So they're a little confused when they come in.
Yeah.
Up in the Northeast, it's a pretty well-known Tuohy kind of Irish name.
Gotcha.
And then when I went to college, my parents moved from outside Philadelphia down to High Point, North Carolina. And so I originally started at University of Michigan and then transferred and finished at the University of Chapel Hill, which is a great place. Go Tar Heels.
There you go.
And then I spent some time working in a lab and eventually went to Wake Forest for medical school. And then did most of my training back up in the Northeast. I did my orthopedic residency back at Albert Einstein in Philadelphia, a shoulder and elbow fellowship at Thomas Jefferson in Philadelphia, and then a hand fellowship at Vanderbilt just over in Nashville.
Okay.
So
cool deal. So what made you want to become a hands, elbow, shoulder doctor?
Well, it's a good question. I mean, most people are going to give you the canned answer of, hey, I went into medicine because I want to help people. And there's a lot of truth to that. It is very satisfying, I think.
Sure.
Especially with, what we see now with most folks in terms of motivation by folks like Daniel Pink, that purpose is a really important thing for people. And so medicine's one of the ultimate places that never changes. We still have great purpose in terms of what we're doing. But orthopedics is fun because it's you're helping people enjoy life still, and a lot of the things we're doing, although most of them are elective, people find that very satisfying to get back whatever function is it that they were losing or lost. In particular, shoulder, elbow, and hand. I was interested in doing all three of them because of the fact that they're integrated together. You need your shoulder to get your hand out in space. You need your elbow to be able to retract your hand in and out of space. And then your hand is your primary sense organ to feel things in the world, but then additionally to be able to grasp things, interact with the world. The way to think about it is, you have five senses, sight, your eyes, nose, smell, but your hand is what you do to feel and your touch into the world. And so you need all those things to really work effectively.
Yeah, that's a really cool way to put it, actually.
Thanks.
So remind me, how long have you been here at Wake Forest Baptist now?
So I've been here for over 10 years. I came here in 2008. And my practice has evolved a little bit where it's kind of funny in town where half the people know me as a hand surgeon and the other half know me as a shoulder. So having the opportunity to talk a little bit is great and let folks know that I do a little bit of everything from that point of view.
Sure.
Now realistically, probably about 60% of my practice is shoulder, about 10% is elbow, and 30% is hand.
Okay.
So
cool. Well, speaking of doing a little bit of everything, you also like to dabble in research. One of the great things about being here at Wake Forest Baptist Health is we're an academic medical center.
Right.
So I don't know if you just want to touch on what you like doing a little bit of research on when you have that time.
Yeah. So I've kind of when I first, probably 5 or 6 years, I really was pretty focused on rotator cuff research. We did a lot of basic science research, and spun out of that actually even a patent in terms of some ways to tension rotator cuffs to figure out if what the appropriate level of tightness is when we're fixing things. That's still in the process of being studied, and we're collecting data for that. But that's where sort of my passion is. That's sort of also where we've learned a lot, and things have changed a lot over the last 5 to 10 years. Not just what we're doing here, but across the nation in terms of what rotator cuff things need to be addressed and why.
See, I love hearing cool stuff like that when you're talking about, sometimes when people go into great detail about research tactics and goals and objectives, it can come across to the common person as maybe not the most exciting thing.
Right.
But to be able to hear about how it gets transferred over to the clinical side and it's helping patients at the bedside, I think it's pretty cool.
Yeah, and the other part of it too now, which is interesting, which kind of blends a little bit of what we're doing here right now, is that I've gotten pretty interested in the informatics side of medicine. EHR is really, or EMR, as most people kind of talk about it, is sort of changed the way we approach things. And one of the issues we have now moving forward is getting the data out of these software programs so that we can help patients better in terms of knowing exactly what they're feeling and why they're feeling it and how we can make our outcomes better. And that's been a tricky thing. So much of what we've done up until all of that came in, Wake One or Epic and all these other companies, everything was manually done. And so there's the opportunity now to help collect that data in a much more efficient manner.
Sure.
So,
well, you mentioned rotator cuff, with the shoulder episodes that you see in clinic. Is that still one of the most common injuries or ailments to people? Is people, they come into your clinic and they have rotator cuff issues? If you just want to talk about kind of what that is and maybe why are the main reasons that gets hurt?
Sure. Well, I would tell you, in general, the number one musculoskeletal complaint that people come in for is back pain. And, and then knee pain used to be 2 and shoulder used to be 3, and it's actually shoulder and knee have flipped. So shoulder's the second most complaint that folks will come in.
Interesting.
In to see us. And it can include a whole wide variety of issues, and they're usually pretty directly related to people's age. So, if I have a patient that comes in at 30, I don't really worry about the rotator cuff unless they had some dramatic traumatic injury, like they fell out of a tree 25 feet. But so the classic patient that comes in with a rotator cuff problem that I worry about is late 50s, early 60s, and so what a lot of the times I'm usually diffusing and debunking with patients is that a lot of rotator cuff problems are simply genetic, and your rotator cuff degenerates. It's what the analogy is it's like, the tires on your car is that, they wear out after, 50,000 miles or 60,000 miles. And so your rotator cuff, because we all live so much longer than we used to, it degenerates in some patients, and then eventually that it tears. The thing that I like to point out to folks, though, is that a lot of folks learn to live with it, and it doesn't functionally affect them as much as they think. And so we work really hard in terms of making sure the patients understand that when they come in, that just because they have a rotator cuff tear doesn't mean they're going to need surgery. Because all my patients that come in for the first time or for a couple of times, they have some friend who had some disastrous shoulder experience, and they were never the same after that. So.
That's interesting. So maybe for some of the younger patients that you see, if it's not rotator cuff, what are some of the episodes or diagnoses that you're seeing with some of the younger patients? So
my sports medicine colleagues usually see a lot more of those patients than I do. Okay. But the most common things for those folks are shoulder dislocations, collarbone fractures, shoulder separations, and then usually labral tears, and your labrum is a soft tissue inside your shoulder. The analogy I tell my patients when I'm talking to them about is it's soft tissue around the socket, and what that does is it's essentially like a suction cup for the ball to stay stuck where it's supposed to be.
Sure.
And when you have a tear with that, one, it may just cause pain, which it can, or if you tear in a particular location after dislocation, then what happens is folks then have what we call recurrent instability, or meaning they'll continue to dislocate their shoulder when they put their arm in a particular place.
Interesting.
So.
So we'll move down the arm a little bit to the elbow, I guess, next. So one of the more common ailments I hear around the elbow a lot is tennis elbow.
For sure.
I don't know if that's what you hear or see a lot in clinic, but just talk about some of the common elbow diagnoses you see.
Yeah, fortunately, elbow I would argue it's probably the most important joint in your arm because you can't compensate for loss of motion with it. Mm-hmm. And so, if it gets stiff in one way or another or hurts and you don't move it, it mm-hmm. makes life really hard because you want to get your hand to your face and your hand to your bottom. Mm-hmm. So
important.
The two important places.
Yes.
For two different reasons.
Yes.
So, but most commonly the things we see are tennis elbow, which is called lateral epicondylitis, or golfer's elbow, which is medial epicondylitis. And interestingly, despite the term itis, which implies inflammation,
right.
Neither one of these are inflammatory problems.
Oh.
They're tendon degeneration problems, just like what we talked about with the rotator cuff.
Mm-hmm.
And so they're again something that wears out. You classically see people come in with these symptoms, in their 40s. And I jokingly will tell them it's the gateway to middle age is what they're suffering through. But fortunately, I tell people that they're self-limiting processes and they go away, but they can take 6 to 12 months to go away, and it can be pretty hard because they affect gripping significantly. And so, if you have a job that requires a lot of gripping or a lifestyle that requires a lot of gripping, they can be pretty debilitating in terms of what you want to do.
Sure. So, speaking of, what obviously you and your colleagues are here to help people get back to their active lifestyle or their normal lifestyle for job duties. If you would talk a little bit about what, there's a whole spectrum of things that you can do as a doctor to help a patient. At one end of the spectrum, we have surgery, but there's other things that are non-surgical. So I don't know if you just want to speak to that very briefly about some of the different options, and it doesn't always require going under the knife.
For sure. And tennis elbow, I will use tennis elbow as an example because mm-hmm. it's a good example. I mentioned that it's a self-limiting process, which mm-hmm. means it goes away on its own. It doesn't need actually really any treatment at all. So all the things we do for it are ways of decreasing your symptoms so that you can tolerate the problem until it eventually goes away. Mm-hmm. It's a challenging problem because everything we do to treat it has about the exact same success rate. So if you do nothing, about 85% get better. If you do some steroid injections, about 85% get better. If you do some physical therapy, about 85% get better. And then there's all kinds of other things out there in the world that people read about and they come in, things like holotherapy, which is not holotherapy, pylotherapy, I think is what it's called. It's with water.
Okay. And
then people come about laser therapy, and there's surgery on there too. But what we know pretty clearly, at least for surgery, is that I won't offer anybody surgery before they've had symptoms for 6 months mm-hmm. because I know that it's going to go away. Mm-hmm. And when I first started practice, it was 12 months, and that was usually generally what people agreed to, mm-hmm. or the experts out there. But some of the financial analysis has shown that at 6 months, it's still financially it makes sense to do surgery for certain people. If your job is you're working in a factory and doing a lot of manual work, you can't sit around at home for a year waiting for your tennis elbow to heal.
Sure.
So those are all the things out there. And then, I'll additionally talk to people because some folks, it's the other thing I emphasize with tennis elbow is it's really just a pain problem. And mm-hmm. so the pain causes you problems in terms of using your hand. Mm-hmm. And so I'll try almost anything with people and, to keep them out of the OR because I know it'll eventually get better. And a lot of folks, when they know that, want to try almost anything. So I'll even try other holistic things like acupuncture and things like that for folks to avoid surgery moving forward.
That's interesting. Cool. So we'll continue our trek down the arm and we'll get to the hand. So these days, what are most people talking to you about in clinic with their hand problems? What are you seeing a lot of?
Well, probably two things in my practice, and the two most common are clearly carpal tunnel syndrome. Sometimes folks have done a little bit of search on their own at mm-hmm. the website du jour, mm-hmm. And they're convinced that's what they have when they come in. And And because it's such a common problem, they're often right. And then probably the other most common thing that I see is base of the thumb arthritis, which we call basilar joint arthritis or CMC arthritis of the thumb.
Interesting.
Which is very, very common in women, about 4 to 8 times more common in women than men. Wow. And they often come in their 50s with a lot of thumb pain.
So is that just overuse or degenerative based on your age or a combination? Or?
So we think the reason why women are more prone to it is because they're just naturally a little more loose jointed from their estrogen and hormones.
Okay.
And so that joint doesn't have natural stability. It's basically 2 saddles against each other.
Okay.
And so the ligaments keep everything stable. And so over time, when those ligaments slowly stretch out because of the hormonal kind of things I just mentioned, shearing of the joint will cause it to develop arthritis. Gotcha. And so, I mean, I see folks all the time that come in, I'm looking at their hand for something else, and it's very clear that they have deformity consistent with it.
Sure.
Fortunately, 70 or 80% of people learn a little bit that they adapt to it. It hurts. And so, they learn how to do the non-operative kinds of things to make it, tolerable. Sure. So.
Well, one of my family members a few years back, they had carpal tunnel pretty bad. They had to have surgery.
Right.
But once again, there's the spectrum of services or treatments available. So for carpal tunnel, there could be surgery, but then there's other things to help see if that can help get the patient better. Is that correct?
Yeah, there are. I mean, I would argue that I have carpal tunnel, but the only time mine's symptomatic, consistently symptomatic, is when I would go mountain biking.
Okay.
So it's hard for me to justify going to have surgery just so I can go mountain bike more. I get it sometimes at night. That's one of the most common things we look for is folks wake up and their hand feels numb.
Okay.
And that has to do with how we sleep.
Yep.
We tend to sleep with our wrists bent.
Yep.
So the first thing we do in terms of treatment for that is we give people some splints to wear at night, and that keeps their wrists straight, and so they tend not to sleep in a fetal position, which is how we all naturally want to sleep.
Interesting.
So that's the first thing we do. That usually helps people in the earlier stages. And then the next thing we usually consider is steroid injections, which are quite effective.
Mm-hmm.
They don't, in general, we got real percentages for it, but probably only about 25% of people will have steroid injections and have their symptoms go away and never come back.
Mm-hmm.
So in general, I would say most people that end up with symptoms are usually going to end up probably going towards surgery at some point a lot of times, because it simply comes down to with that disease process, you have a nerve and a small tunnel with 9 tendons. And so It's just a volume issue. And so if there's something affecting that volume, there's not really a way to change that. So some people, it's just anatomy, and over time the nerve gets unhappy.
Mm-hmm.
For some folks, like rheumatoid arthritis, there's inflammatory tissue that's in there.
Mm-hmm.
For some people that do a lot of heavy gripping activities, their tendons develop a certain amount of film and inflammation around them. And any kind of volume thing like that's going to affect it.
Okay.
So a lot of times people end up towards that. But what I would tell them is, and I'll say it here as I do, is the 2 happiest patients I have are carpal tunnel patients that have releases and shoulder replacements. And the reason why, and it's nothing that I do for them, the reason why those surgeries are so good and so successful is because they're reliable. They get people rid of people's symptoms reliably almost every single time.
Sure. Well, I have another question. So we were at an event last week, and we had a few people in the audience at that event mention something about trigger finger.
Mm-hmm.
I don't know if you could just briefly talk about what that is and,
sure.
and how to treat trigger finger. I think we're hearing that a little more frequently these days.
Yeah, it's a problem where people develop the swelling in the tendon. Your tendon is a rope that connects the muscle to the bone,
mm-hmm.
and when your muscle pulls on the tendon or the rope, it moves then the bone that it's attached to.
Mm-hmm.
And so your tendons in your hand, they all sit in these really tight little tunnels, and there's really no extra space in there at all. So trigger fingers essentially have to do with where that tendon starts and enters that tunnel is right at about in your palm towards the end point of it.
Okay.
And so we don't really understand why it happens, and we don't know if it's a chicken or egg thing, but people develop some swelling either of the tendon, which then starts causing thickening and tightening of the tunnel. Or if it's the other way around, the thickening and tightening of the tunnel causes the tendon to get swollen. But either way, the point is that the tendon gets caught trying to enter that tunnel, and it causes pain. And that's the first thing people feel, is they'll feel pain in their palm. They don't really understand why that is. And then later they see the flicking that happens as the tendon kind of pops through.
Mm-hmm.
And so fortunately, if there's really two kind of groups of it. There's the idiopathic group, which is the run-of-the-mill person that develops it. Lots of people develop it. And then there's other people that have swelling in the tendons for other reasons, like a rheumatoid arthritis patient, or diabetics have sugar deposition around their tendons that causes the swelling and the difficulty sliding through. And so if it's an idiopathic or no good reason kind of person, injections a lot of times will help them and get rid of their symptoms. They don't need surgery, especially if they come in with symptoms that are less than a year.
Mm-hmm.
But if you have some of these other disease processes like diabetes and stuff, I tell the patients, we'll try an injection. And I do it also for diagnostic reasons for the patients, because they come in and, they want to know what they have is what they have. And it still will get rid of their symptoms in diabetics, but the symptoms always come back. And so, but it's a great way for the patient to gain a level of trust with me and see that, like, oh, well, this is what it is because I got this steroid injection and my symptoms went away.
Sure.
And so what I tell folks then is the surgery is basically a permanent way of getting rid of the symptoms versus the injection is going to be temporary for somebody like that.
So let's say that someone has maybe one of the ailments that we've discussed, and theirs is at the level for which they're going to need some sort of surgical procedure.
Sure.
Generally, people don't like to hear that they have to have surgery and someone has to cut them open and do something to one of their joints.
Right.
So I guess just if someone that's listening might have a problem with their shoulder, or they might need surgery, or on their hand, what's some things that you could talk about that would I guess reassure them that the surgical process we have here at Wake Forest Baptist is, we have a good pre-op, op, and then post-op whole navigation process. So I don't know if you want to talk to that just for a minute and talk about what y'all do for surgical procedures and how you get people back to being healthy.
Well, the first thing I would tell you, at least in my clinic, what I really emphasize is that a lot of what I do is elective, and I try to make sure people understand that
Okay.
If you lived, we're pretty lucky. We live in a country where we can have a lot of things musculoskeletal operated on that in many other countries would not be addressed. Like you would basically be given a stick to go chew on, and you'll deal with the pain and move on in life.
Yeah.
So we're very fortunate in the United States. Sometimes and so I really emphasize that to the patients is like, this is an elective thing. Ultimately, you don't have to have surgery. I mean, there's, if people have something that's broken, that's one thing. But
sure.
A lot of what they're coming to see us about are wear and tear, degenerative kinds of things that are going on, whether it's tendonitis or arthritis or some inflammatory thing like trigger fingers, like we just talked about.
Mm-hmm.
And so that's the first thing, is I want folks to be 100% comfortable that they're they're going to have surgery. I just recently had surgery, and it's you going through it actually gives you a very good very much better understanding of how patients are giving up control and the trust that they're giving a surgeon to let somebody perform something invasively on their body.
Yeah.
So I'm very careful with that. I would rarely ever, for that reason, to help develop a relationship with a patient, I would rarely have a patient come into my clinic and tell them, hey, they need an operation the first time they come in.
Sure.
I mean, if they come in with something that obviously needs to be fixed, like they broke their wrist, that's one different thing.
Sure.
But it's important to have that conversation so that they trust you in terms of what you're doing. So that, at least in my clinic, that's the way things go. And the other thing that's excellent here is we have experts everywhere, and so if there's things that we're not sure about, we can get you to the right folks to make sure that we're not missing anything.
Mm-hmm.
Make sure that folks medically are completely healthy enough to have surgery, so we're not taking any kind of unnecessary risks for the patients. And then the other thing I would just tell folks is that. Especially here, we've all spent an extra year or two doing specialty training, so we're all experts in terms of what we're doing, so people can feel confident that, they're getting the best possible care they could be for whatever their musculoskeletal orthopedic problem is.
Yeah, that's a great point. And I just want to let people know, if you're listening and you're having some sort of discomfort or pain in your elbow or shoulder or hand, Dr. Tuohy or one of his colleagues, they're a great resource. You can reach out, and they're going to provide a lot of valuable insight for you and a diagnosis to help you along your journey to get back to being active. So a really convenient way to get a hold of them, I'll give you just a couple of options. People can go to our website, wakehealth.edu/ortho, wakehealth.edu/ortho, or they can call 336-716-WAKE. That's 9253, 336-716-9253, and make an appointment with Dr. Tuohy in his clinic, or one of his colleagues. We have ortho clinics for hand and elbow and shoulder. We have physicians all over the triad in Northwest North Carolina, so we can help people in this whole area. And we're going to wrap up here soon, Dr. Tuohy, but I guess just talk about, if you could share just a quick story of, have you had a patient? I'm sure you have. But someone who's had to have surgery, but then they're back to 100% health. If it's a shoulder replacement or something with the hand, just kind of having them come back and be at 100% again. What's that like?
You asking for an example, or how it makes me feel?
No, how it makes you feel, how it makes the patient feel. I mean, it's.
It's part of what we do. I mean, it's what makes what I do for a living so satisfying. I've had lots of great stories, both trauma-wise and non-trauma-wise, of folks that come to see me. I had one woman in particular that came to see me. I remember quite well that she had broken a wrist and it healed in a bad position, and she had seen 2 other people, and they had suggested, based on how bad it was, that she should just have her wrist fused, which means basically having it heal together so it doesn't move anymore.
Oh, wow.
And so I told her that I said, we can try to go back in and realign everything, and we did, and she did far better than I ever thought she would have. I mean, she gained back almost all of her wrist motion. But, the best part was then over the last couple of years, she always sends me a Christmas card of her and her grandkids. So it's great seeing all of that, when you can help somebody that way.
That's awesome. Well, you can check out Dr. Tuohy's profile or any of our other orthopedic surgeons or doctors' profiles on our website. And like I said, you can find out more information about our services, wakehealth.edu/ortho or 716-WAKE to make an appointment. Also, a quick reminder, you can check out wakehealth.edu/besthealth to listen to all of our podcasts, including this one. So, Dr. Tuohy, once again, thanks so much for visiting us this month. I really appreciate it.
Thank you. I appreciate being here.
Yeah, thank you. And we hope that everyone listening has a great June, and we'll talk to you again next month. Have a good day.
Thanks for listening to this episode of the Best Health Podcast, brought to you by Wake Forest Baptist Health. For more wellness info, check out wakehealth.edu and follow us on social media. Wake Forest Baptist Health, the gold standard of healthcare.